Good morning, everyone. We are happy to have Dr. Bhuneshwar Prasad Mishra ji sir with us. He is professor and head of Department of Clinical Psychology, Dayanand Medical College Hospital, Ludhiana. He is the professor of eminence and is having RCI licensed clinical psychology. He has a vast experience of research, publications in both in research papers and books. His specialization ranges from dealing with the mental health issues of children, adolescents, adults. He is professor of eminence and IACP fellow membership, lifetime member of National Medicos Organization, member of Indian Epilepsy Association, member of Somatic In Blood Test Society. Sir, with your permission, shall we start?
No.
Yes.
Good morning, respected sir, and thank you for taking your time to look into my presentation today. To the esteemed panelists on board, my name is Feba and I was supervised by Dr. Vijayendranath Pathak, and the topic that I will be presenting for my PhD thesis Viva presentation final is vicarious traumatization in mental health professionals working among children with disabilities and its impact on mood and hope. I would like to give you a quick highlight on what you're going to be with me or to understand with me what I did through these years with the help of my supervisor and the team that supported throughout this process. This research has a potential of having a clinical perspective, an educational perspective. It also has an organizational behavioral perspective. It also has a counseling element to it. These dimensions are so vital in today's medical professionals that where I serve and where I work, this works as a foundation of preventive and awareness-based model of care, which comes before primary, secondary, and tertiary care. The sample of population that I took, I chose to be with the population in India because I wanted to study and make a model that can be incorporated to my population first before I can even make it into a patented project further. But the idea was always to go forward with an action plan, do a pre-test and post-test, put an intervention, see how it works, and then the intervention should surely become a part of a benefit to the society in general. Vicarious traumatization might look like a very big twist of tongue, but in terms of how it is called, it can be also called secondary traumatic stress. There are other terms, but this is the closest that fits according to Perlman. Now, what happens in it is that a person who experiences traumatization by being there, present, as a secondary person to that event is who it is affected to. It occurs indirectly to caregivers, and this became a huge area of review and research during the time of pandemic, and it has been ongoing in terms of research work post-2019. Now, when we look at who got this term out, they have significant topics to talk about in terms of DSM-5. We might look at adjustment disorders, we know about PTSD, but vicarious traumatization is an ongoing project. It means it's something that we as clinicians want to incorporate in order to understand how are we as caregivers doing in mental health. The second definition that I want to bring in is CWD, that is caregiving for children with disabilities. Now, when we have a definition there, it is based on World Health Organization, WHO, but disability has a different element I want to highlight. It is about the negative interaction between a person with the health condition, but also their environment they live in. That means, are they able to adapt there? So, which also brings into the picture the caregivers who are going to be helping them play a huge role in their health condition. So the second definition that has been put here is a person with a disability, to be more inclusive in my language so that we add the person first and then the concern next. Now, when we look at the introduction part of it, there are a few theories that really highlight this beautifully. One is, when I like it, is to do with self-development theory of constructivism, which comes from Bandura for sure. But if you look at what we are seeing here, it is the individual's idea and knowledge, that is me as a clinician, as a caregiver, as a person who is going to be probably a clinical psychologist or a special educator. What is my idea and perspective before I help somebody else. So I have a construct in my mind that I make, a perception. A person apart from us, there are others who are around. How are my emotions doing before I intervene with a second person? Because that is going to make a decision on whether I will be able to heal the other person. That comes to the emotional intelligence part of it. EQ has been used as a testing tool now in all over the world with organizations, including where I live. It's a huge paid project that they want to know whether the person has the adequate emotional intelligence to work on it. Now this goes back to one of the evaluator projects that have happened in the concentration camps. So when Hoppe did it, he wanted to study what happens to caregivers when they are in a traumatic situation. And he found out attitude differences. So there's knowledge, there's perception, there's attitude. So attitude, there was denial, there was rationalizing. Oh, I don't think there is a problem with the child. It's something that I will come with when I come forward. Rationalizing that there is an understanding that I know everything probably. This is something that Hoppe brought out. Over-identification. I feel the victim more than anyone else. Then you also brought controlled identification, which is something that they are losing an objectivity and putting the control over the experience that they feel inside them. Now, empathy has a huge area of work again. Some persons are made highly compassionate, but altruism comes with a cost. And that is where cognitive processing model also comes into place, and let us get to thoughts and cognitions. Social learning theory helps me to understand further that people observe and understand and adapt it to the society based on what they experience in traumatic experiences. Further, if you go to review of literature, there is a beautiful review that has come in, wherein social learning has understood that any person coming from a vulnerable group that has experienced trauma before will experience too heavily when they meet a child or someone who has been coming under the 21 categories of disability as per the Indian rights. So what is the risk factor? The risk factor is that I'm a caregiver. We are all caregivers. But the tendency or the desire to understand others is something that we have to take into picture, because if we neglect our well-being, we're not helping, we're not healing, we're harming. What is the allostatic load? How much amount of burnout is a caregiver going through? And how much of it? So in vicarious traumatization, if you're working with children, it becomes even more sensitive, which means the highest rate of dropout. If you look at the prevalence rate, there is something I want to show. 60% of mental health professionals who they report experiencing symptoms of vicarious trauma sometime in the point of their careers. So this research is 2022, it's not far. So which means it is a topic that we have to address. And mental professionals have limited peer support sometimes. They might look at more competitors because there is a world that is, sometimes we have great peer support. Then sometimes there's a huge heavy workload being put on the person. I'll give you an experience. During my research, I met the organization and I met Pooja Bhatt, the sister of Sanjay Dutt. Yeah, so it's Pooja Dutt. So I met Pooja Dutt, and we were having a conversation about the Nargis Foundation, which is in Mumbai. Being a celebrity, one of the things I thought was she would come up and say, how can I make my organization popular? But she didn't do that. What she came and asked me was, okay, Feba, so I know that you're working with people who are clinicians, you head a department, but then how do you work on employee loss? Like when they just leave the company, leave the organization. In my unit, when I'm in Mumbai, I have a Nargis Foundation. I have caregivers looking for cancer patients. I have caregivers looking for children with difficulties. But there is a lot of people leaving my work. What's happening? And that's when I pulled out the research and I told her about the university, and I said, I'm working on a model that should show us how can we help the people who help others. Because if we don't do it, then the one thing that's going to happen, ma'am, is that we might just quit midway. We might become wise, we may become people, yes, great, we might stand up, but a lot of dropouts in the field of this career. We might just get into a comfortable zone and do something. So she understood, she sat down, she looked at the model, and then she said, we are going to do it in Mumbai, which means there is an outcome to what we are doing today. There are some things that I have seen is that there's a lot of neglect, because being caregivers, we neglect a lot of who we are for the other. And that is a consequence that research shows. In 2023, Velasco said that there's a heightened risk because of the personal life we follow. And we do not do a great job. I include myself, we all do that. But a regular supervision, access to counseling services, And knowing or training about self-care can actually foster a supportive work environment. I also want to tell you that we need to be aware of some terms like compassion fatigue. It has originated from that. We need to know about narratives of PTSD that was being used before by Bride and many other people, so they have highlighted this term before. I also want to bring into notice about individual factors, because some coping strategies and adjustment disorders have similar tendencies. Please understand the etiology and the beginning of all this has come from people who have worked before in it, but then there is still a lack of resources, and that's why I highlighted lack of resources, limited support system, and that is why, because of that, the prevalence is increasing. How is the review of literature? Review of literature has a huge work on personal trauma history, which means when I started my career in psychology, which was 2011 or 10, I was a student, only teenager probably, and my professor said, if you want to help somebody, Feba, in Hindi, she said, Apna aham bhav hatake, first go into therapy. And that applies to all the 48 students on board. All of us as students went into therapy first. And that was a fascinating perception, because being 90 plus scorers in a university like that, all of us were high on our ideas, but it broke us. And we learned that there's so much we need to work on ourselves which is hidden, so much of the unconscious that we talk about. And that's where peer support became better. We became friends more than we became competitors during our degrees. And we're still in contact to help each other where we are. And this effective coping strategies, personal trauma histories have to be cleaned out. There's a lot we need to do. Without proper training and preparation, I don't think we're going to have a world helping others. How is the psychosocial factor? Now, when you look at the whole picture of this, social workers can help, educators can help. Excuse me, I'll take it as water. Wrigley says that mental health providers are trained to be compassionate while also being objective and analytical. That means we can use our left and right brains very properly, in terms of how we can construct a more switch on and switch off method. Like, I'm sorry, I'm out of the flu. In terms of how we can be objective and analytical at the same time. Sorry. Yeah, I came out of an influenza A. I will request your compassion. So sorry. Yeah. Now, when we look at it in terms of the point that I was talking in terms of objective and analytical side of us, we can have a framework. We have the ability, as per what Wrigley says, is that in order to be more practical in our guidelines and policies. Again, I want to share an experience here. During this research, what happened is that the organization I worked with asked for a policy from us based on the guidelines that we should follow as caregivers. Because it's a hospital, we had nurses, we have staff, we have people working with children with difficulties, And we made a policy and guideline of how and when should we enter into peer support system. It was a beautiful journey to instill a policy under the health regulator, national health regulatory system of the country. When the representatives came and heard it out, they said, where did it all begin? Like, why did you think that we need to? And this is where this research application comes in as a future outcome. Because anxiety and depression was seen even among people and nurses in their research who work with neonatal babies, or probably children who had to pass away or they died and the parents and the caregivers were outside. So you could see this happen among children with difficulties, and the ABA therapists who were there, applied behavioral analysts who were there, sir, they also started having panic attacks when there were parents who got tougher on them. They would breathe heavy. There was experiences of even being sad and not coming up for work, because what happens is that they feel not only burnout, they felt like there's a loss of connection, they feel like there is no hope. That was the element of hope. Apart from mood, the reason I took up the element of hope was, are they really goal-oriented even in the future when they work? And then among the Indian emergency responders, there was a research that took place which in 2022 during COVID, where they said that we need intervention strategy. We need, all of it shows we need ethical principles, we need strategies. And that brought me to some terms: mindfulness, self-care, professional supervision, race and gender matters, which means we have to do this as a part of my research work. And few interventions and therapies that highlighted in my mind was trauma-focused CBTs, mindfulness and stress reduction, MBCSR, eye movement desensitization, support group, psychoeducational workshop. How are we going to put all this together? And I thought about, we need self-care also, we need to educate. We need to also find out training and development for their, and all these processes, because people even don't know the term of vicarious trauma when I started off to talk to them. Identify the best possible intervention is something I was also thrilled about. And then was it evidence-based? Based on that, I got some research gaps. And I understood what are the research gaps do we have here? In the whole terms is that there's a lot of work among the victim perspective. That is, if the person is not well, that is the PTSD is among the patient, if they call it, or a client or a person. But what about the person who's taking care of them? So let us do more work. There was a research gap on investigation about hope. That is, do they have anything or a goal-oriented according to Snyder's theory? Do they have a goal-directed principle? How about their mood disturbances? Are they really upset when they go and work with people who are all with children with determination? Are there any issues like that? So all of this brought in questions, and I came up with one of the plans. This was with the help of my supervisors and everyone on board, continuous evaluations that happened. Pre-test and post-test is a great research method to find out whether we can use a sample and then randomly put them into groups. Moderate to high scorers in these assessments were put into two groups. And one was the control and one was the experimental. The control group was not given an intervention, and the experimental group was given an intervention and then evaluated after that. What are the objectives? To investigate the levels of vicarious trauma in mental professionals working among children with disabilities, to explore the mood states in mental professionals with lower measures of vicarious trauma working with children with disabilities. So mood states, to find the mood states in them with higher measures of vicarious trauma, to find out and examine higher measures of vicarious trauma, do they have an impact on the levels of hope? Lower the vicarious trauma, how does hope look like? To affect on the intervention. So if you provide an intervention, how does it work with interventions? And in terms of intervention, where are they at in terms of the experimental group? To examine the levels of vicarious trauma, mood and hope for those who were provided or not provided to. So the objectives brought out hypothesis. In the hypothesis, the first is a null for sure. There will be no significant difference. That is, probably there will be no difference in the mood of people. Then we looked at maybe there will be no significant hope level differences also. But if you look further, we looked at alternatives. Alternatives were that working among children with disabilities and lower vicarious trauma, did it have lower mood disturbance in people? Working with children with disabilities, higher vicarious trauma, did they have higher mood disturbances? Similarly, did they have high impact when it came to high vicarious trauma and then the hope reduced? How were the levels when intervention was provided? Did it decrease the levels of vicarious trauma? Did it improve their hope? Did they have mood elevations after that? The sample was taken, and out of 250 people, this is how we looked at it. We had therapists, we had special educators, we had psychiatrists and counselors. We had mental health professionals in these areas who were dealing with children with disabilities only. And that was the inclusive criteria that they have to be 25 to 35-year-old and 125 of male participants, 125 female, very tough. Let me be honest, we have more females. I'll be very honest, as one of our limitations, but it is possible in the years we spent in looking out for every male. But it was possible to find psychiatrists, it was possible to find counselors who are working with children with difficulties. we provided the 3 questionnaires to them, but I have to tell you about some exclusive criteria. I needed to tell that family members cannot be part of it. I had to tell them that housekeepers are not caregivers, because that is the term we use in the West probably very often. But then, did they have comorbidities? That means nobody in the 125 or 250 people should have any PTSD diagnosed in the latest of 2 years. So some things were excluded, head injuries if there are any. So some of these guidelines were provided. 3 tools were used. FORMS-R is great because it has areas that will look into in terms of tension, depression, anger, fatigue, confusion, vigor. So there are good areas of mood that can be evaluated. It is good with this reliability and validity, very consistent, has a good measurable content and construct. How is Adult Hope Scale? Adult Hope Scale helped me a lot to get into what they feel in the 12 items about their hope, or do they look forward, or are they goal-oriented? Then we looked at Procol 5, very used research in terms of, again, nurses, but not in our area much. But then when we incorporate it here, it gives us a very good score about caregivers and how they feel in vicarious trauma. How was the procedure? Yeah, my attempt 1 was not great. Let me be honest, sir. My attempt 1, I sent e-copies on Google Form. I thought this can be done with the 3 tests and it's going to be completed. No way. The piloting went really bad. And because several reverse scoring was there. And out of, conducting 3 tests simultaneously, only 7 participants completed it, you know. It was such a sad impact. But then I thought, what can we do next? So I did attempt 2. Now I took 20 participants and then piloted with 20 again with a new method. And I found out that if it is given to the counselor or to the psychologist or to the educator that, okay, you can evaluate the test on your own. They felt very empowered. So they did the whole testing on their own, evaluated it, sent it across. So that way, it helped me to get the scores down. So it was something like an activity for them, and it was really something they looked forward to do. But when's the next test? When's the next test? Yes, sir.
Okay, you can carry on your work. These 2 are my students. They joined here at faculty. So I wanted to see them.
Class later, I can say. Many things. Oh, sorry. Last.
लेकिन फिर हमें सर से मिलना भी है और से वालों को।
So the second attempt brought in the results at least, because the first attempt I knew that maybe we were trying to do it too quick. Second, gave them the power to finish the assessment and see the report, because these are self-report questionnaires. And it helped them to give me the scores too. On completion, we could get a data for sure. Data analysis was done. We did the post-P test. We know that we did a t-test scoring, which is something I can show you forward in data. But the intervention is also important, because after the post-test was done, we segregated the experimental group and intervention began. There were 3 kinds that I picked up. One was Jacobson's JPMR. Now JPMR looks like a very common activity, but when you do it to people like psychiatrists and counselors in return, it takes time to make all of us sit down, you know. And then we know it, and then you see that they would try to get themselves to do it. But to guide them, saying, no way, we're going to do it together. And they would sit down, because 25 people were allowed to be in the room in this training. Sometime I might share the photographs with consent, but it is wonderful to see how they sat down with it and they did the breathing exercise. They were able to finish it and they said, actually it has an impact. So I asked one of the psychiatrists, Doctor, have you ever done a JPMR on yourself? And he said, I would never even think of it unless you would have said it. So true, because we would never try to do it on ourselves, right? But mindfulness-based, stress reduction. So when we did trauma-informed cognitive therapy and MBSR, we made a group. We made a circle-based sessions, because one-to-one sessions, we know that it is going to be something where I can get perspective from them. But when there's a peer support concept, like the review of literature said, this was the only way. So to add the peer support concept, we were in a circle, we sat down, and we started building trust. We started doing activities. I would like to show you the brochure that was given to them. Let me quickly take you to that. So this was how it was introduced to the organization, with a brochure first. First, probably they just kept it in the room. So we go back to them, we tell them, you know, and it's okay to ask help even if you're great at giving help. Let us start this, like a psychoeducational workshop. Is there going to be a cost involved? I said, no, we are starting on because it's a project, we're not funded. These are common questions that came up. Oh, you're going to take all our work hours? No, it's going to happen only in 3 days. Let's do this. Lot of convincing, and then the organizations agreed. It was not, again, simple. I gave them the demographic information sheets. They filled it up, but they didn't ask me to keep the name because organizations knew if there's something that comes up, then of course they will be, questioned about it. So that's a confidential part of it. And then we started this flow. First with the awareness, that means I had to sit down and talk to them about what is vicarious trauma. It is important. So I made a presentation that was simple for them. Can I just move from this slide to show you that? I would like to give a little bit there where I remember. I have one of the PPTs. I'm just trying to look at it. Yeah, this one. It's called Happy Adult, Happy Child, because we did not go with the term trauma there. When you're talking about MPSR, we did an aware because it's mindfulness based. So we talked about awareness, we did a mind mapping, and we did accept, we did accelerate, appreciate. Just 5 slides. Because sitting through that was itself, a journey. So all the caregivers, your psychiatrists, you have psychologists on board, and they're listening about mindfulness again. And now we're applying it to them. So this presentation was provided. I also would like to show you something, if I can. There it is there. So this was the JPMR sheets, and first of all, I gave them this to read. And then when we chose which technique, everybody chose this is what they want to do. So this was the poster that was put up for them. This is something that everybody could follow. And the worksheet that I would like to show you is, so this is a simple worksheet, but this is a free resource. And this is what trauma-focused CBT looks like, where they talk about the core belief. Like I said, the perception, based on the review of literature, thoughts matter, attitude matters, beliefs matter, emotions matter. So core beliefs mattered. All of this was one worksheet for them. Simple, yet they could do it. This was a 3-day journey in each organization. So this is where we were at. And going back to where we were in the assessment part of it, like I shared with you, they did the 3 assessments: hope, mood, vicarious trauma, and the action plan was to show them all the 3 methods, and it was done with them together. I wanted to take you through that journey. Trauma-focused cognitive therapy is an upcoming research area in itself, but the result and discussion brought in something beautiful, and I would like to tell you, this is how the data looked like, 50-50%, but we had 60%, more on 25 to 30-year-olds, 30 to 35-year-olds were 40%. This is how the percentage of individuals in the population were. This is a pie chart that represents the data. We have individuals who are higher in their age brackets from 25 to 30, lower in 30 to 35. Education qualified postgraduates were more in the population because they were psychiatrists and they were clinical psychologists and further. And then we had a gender which was equal. Again, like I said, this is a task, but it is, I repeat it because of the, in terms of people collection. But when we analyze the data, this was the mean score. Let me tell you some things frankly. All these scores come above the moderate. And that's fascinating because they tried their best. I have a feeling, because I told them to not lie. When they did this test, they said, we don't have depression, Dr. Feba. It's simply, Feba, we will never do it. And everybody had a comment because we are caregivers. When you look at the scores of these, everything above, in terms of anger, above the score of 7 is it. So you have 7.9. So you're already reaching anger. Then when you look at fatigue, you have again a score of 12, which is anything above 8. Depression, Anything above 8 again has 8.22. So it's unbelievable how a little bit moderately higher there, but when you look at tension, it is really high. Moderately in terms of moderately high, not in the clinical distress, but it is. And then vicarious trauma, 22 and above, it is in moderately high, which means they are 27. They are not there yet in terms of clinical distress, but they surely are at a point where they have to get help. It's not minimal. None of them were mild. So mild, I could at least say, okay, we cannot move ahead with the research. But moderate and moderate above brought in some ideas there. This is a graphical representation of them. But hope, when you look at it and you looked at the scope, post-intervention, hope was already present as high. Let me be honest here. The counselors, psychiatrists and caregivers, all of us are goal-oriented. That's something that I found. We found that it was not low. It was really good. We are all 47. Anything above 30 was good. But post-intervention, there was a little bit more push, which is a great sign. So it made me happy. Now, how did the thing, when we look at it in the terms of tension go? It was higher, but it reduced by a point score. This is three-day work. Imagine replicating this for a good year. So this is a 3-day work, 19, and then it became 16. So it dropped, tension started to drop. When you look at the scores further, you see that it has a significant difference. There is a meaning to our intervention. Then when you look further to it in terms of pre-post and anger, elements of anger, even if 7.94 is somewhere in that borderline, it brought to 7.52, which means our levels can come below 7 because the cutoff is only 7. 0 to 7 is known as mild, 7 and above is moderate, so yeah. So how is fatigue? Fatigue looks like 12.6, it reduced to 11.3, therefore, which is in 3 days. So this is where I was really happy about that. And within 3 days, there is a difference, significant difference of at least a point or one area there. Now, when we look at how does it go in terms of depression, this is good. It came to mild. Anything below 6 is so. In terms of it's coming down, it's not moderate anymore. You don't need a bigger help. Is the intervention working in terms of, is there a significant difference in confusion? Here, we are not confused individuals. So the score here, 5.54, in terms of what you look at overall, might look like a standard deviation of 3.402, and then a little bit of a difference in its, not a much, but there is a significant difference. But the score is still in mild. It is not in heavy. It's not higher. So even if it's mild, it just got better. That's it. But we had good hope. We are not confused individuals as caregivers and counselors and further. Vigor. We are high on vigor. We were always thrilled to take care of everybody. It only increased by a few points. So this is something good. When it comes to vicarious trauma, oh, I love it. This is where I want to show you. The scores were 27.11, which was anything above 22 is going to be, like I said, moderately higher, and we need to seek help. But it came down to 11, a mean difference of 11, which means that it came down to 15.452 as an average score of everybody who was given intervention. This is what I think my heart went to, because I was thinking somewhere 3 days can actually make an impact to call out on people and make a support. Even if it was not a figure, but there is a good significant difference there. And my interpretation of this came out to be that as special educators, clinicians, psychiatrists, psychologists who are being tested, we are good in vigor, we are very vigorous, we want to help, we are not confused, and we have good hope. It got better with the intervention. But we are individuals who might get upset, angry at times, and we are natural and human enough to feel some outcomes in vicarious trauma when we see children especially. And that, with the ability of the 3 interventions, it can bring a change. So first hypothesis, there be no significant difference. No, there was a difference, so I had to reject it. There be no significant difference in hope. I accepted it because there was no significant difference. Hope was always higher in us, yeah? mental health professionals working with children with disabilities with lower vicarious trauma, it's very lower, accepted. It's accepted because the individuals with lower vicarious trauma, but they were all moderate there. Once it was given an intervention, it is accepted there. With higher, there was higher mood disturbance, yes, there was. In terms of vicarious trauma high, whether low, no. Even if vicarious trauma was high, we are still hopeful individuals, so that was rejected. In terms of how we have children with disabilities being worked with mental health professionals, but do they have low vicarious trauma and they have higher levels of hope? Yes, they do. After giving intervention, did it decrease? Yes, it did. Vicarious trauma decreased after intervention. After intervention, did we see that there will be a significant effect on mood and of the individuals there? Yes, there was a significant effect, especially in terms of anger, depression, and confusion, a mild there, but it was there. Hope, I think we are resilient. We are individuals who love healing and we would heal. And we are very goal-oriented if their cultural context is good. Our organization supports us. And I've also learned that providing this awareness and assessment and to provide the action plan for them brings in a difference in the lives of who we are and what we do. Our mood, yes, it starts to get better and we start to experience, because clinical scores in mood, anything higher meant that it is bad. So we start getting less fatigued. We are not tired anymore. And we saw that the role of coping strategies became better because reviews showed that neglect of self-care is very high. If you tell, go practice self-care, the person who says it does it less. So that is something that coping strategies gotten better. How was vicarious trauma? There was an ability to show lesser physical symptoms. That means you're not burned out. And there are no ailments that many of others spoke about. That means emotional regulation, awareness, enhanced ability to know that I have a friend who works with me and I need to check on that person. So there were all narratives that we could collect here. Benefits of addressing this topic, very, very crisp. It reduces a lot of stigma among us, from us seeking help. It reduces organizations from thinking that we could just use individuals and make them work. No, we need help too. So organizations became very sensitive to care. I remember one of the special educational units started with us a train the trainer program, sir. We do it every 3 months once now. It is post the research. Being in touch with her helps me meet 15 individuals in this area and they start talking about how it's so difficult to change some beliefs in our mind and we need help to do it. This is an ongoing process and someday it can become a paid project is what I have a feeling of. My conclusion is that I feel that trauma-informed cognitive care, MBSR, greatly done by researchers at JPMR, which we use, can be also helpful for us to care for us. Designing from here, we can go ahead with tailored models. So that's where I want to come to some limitations. I think we can tailor models for each organization. It can be differently done. There are limitations wherein I know that there are different educational backgrounds, though they come under mental health professionals, but there will be a disparity. But in terms of age factors also, there were differences there. Country, I took NCRs. When we look at NCR area, the area in itself is culturally diverse. So am I good at generalizing yet? We cannot talk about it and I don't know if it is yet. But overall, I know that training, I am starting off a ripple. Maybe it can create a lot of noise later. But the expected outcome from this is for sure a model or a project which is business oriented at one area, organization oriented in another area, clinically oriented in one area. But after all of this, it is to help us get better because when we are happy, we make our people whom we want to make them happy, they become happier too. It has an impact overall. So let us be encouraged. I mean, I'm very encouraged to use this as a tool. But sometimes I feel helpless because of slow results, but I have written that there, that but we can help it become more prevalent and we can use it among all of us. These are the references, sir, and we go ahead to the annexures and letter of consent that I took because the participants need to be there. Organization should allow that. Discontinuing is absolutely their choice. So they were free to discontinue when they wanted. Even if after one test they say, I don't want to do it, I was okay with that. There were these other tests, how they look like. And you'll see that my work makes me feel satisfied. That is Procol 5 for vicarious trauma. So work plays a huge role. Adult host skill, I have been pretty successful in life. That's true, but how do you feel about it? Very good. Adult host skill helped me. Some publications, yes, I was able to publish with Scopus. Again, Scopus publications was a huge journey. International journals would tell me that, oh, this is only centered to a particular area. Convincing them that this is good, but still we could do it. I was able to present it. This time in Bahrain, where I live, in the third psychiatric conference, I was able to present this model out to, this is the first time an Indian is able to talk in a forum, which is not non-Indian. So that was a humble beginning, I think so. And this is how we could publish. One is Indian and one is with Pakistan, because it's an Asian-specific one. I think it can create more impact. We did a publication in a book also, and with adolescents, and I think so far how much I could share with you. I'm open to your thoughts, comments, questions, sir. What do you feel?
Good.
Thank
You
you.
have selected very good topic.
Yes, sir.
But how you was able to control the extraneous variables? For example, say one thing is coping strategies. That varies between genders.
Yes, sir.
But you have nowhere compared the female outcome and male outcome. Was there any difference?
For this time of research, sir, I was looking at whether individuals are aware and can be helped beyond the gender comparison. I would want to see if it was similar, but it is something that can lead to researchers further when we go further. But surely this was something to start a ripple effect. It was to understand that if we made a tailored program based on review of literature, that is the physical signs of it, the clinical signs that showed it.
What I wanted to ask.
Yes, sir.
See, this is mainly based on coping skills and strategies of the individual. That varies individual to individual.
Sure.
And definitely there is a significant difference in male and female adaptive skills. So that part could have been made your study more and more foolproof. Why you are going to use, because you cannot, handle everything with one stick.
Yeah. Yes, sir.
That is the main thing.
True, sir.
And this coping strategies varies. That is why that could have been, because you were doing very good work, you could have compared them.
Sure.
Because 50 male, 50 female, 50% you are taking.
Yeah.
So was there any difference between those 50-50?
Okay, when I'm randomly choosing, sir, the names and the gender was not the highlight of the whole research through, because I was looking at an overall population of...
That's all right. Overall, even if you are planning for any overall, then you can see first in strata.
Sure.
And then you can conclude overall.
Sure. No,
All those can be
yes,
helpful.
sir. This is a very good line of comparison that we can make. But when we were looking at review of literature, sir, male and female research work is only a beginner. Means this is where it will start. It is only looked as how is a clinician doing? Is a caregiver even being provided any help at? So we were at a start of an impact where clinicians, psychiatrists, and everybody beyond the gender can we first look at it. But surely to streamline this in the further, like you said, it can look into a very, comparative situation.
There is research literature that mental health professionals are at high risk to developmental disorder.
Correct.
And that is due to this vicarious trauma.
Yes, sir. Yes, absolutely,
Right?
absolutely.
So in that condition, that literature is already established. Here you could have done something new if you compared the basic coping strategies and then after intervention,
Right.
how it was improved.
Yeah, but so there is also some review of literature that said that the coping strategies used by us were not great, like the self-care systems we had.
There are so many tools.
Yeah, there is.
Coping skills of the person.
Sure. So when we looked at it, they were not great actually. There are researchers that say that. And because of that, I did design this entire model. Otherwise, we would just...
My question is only for your designing.
Yeah. Yes, sir. Yeah. I
Because
designed...
you have limited your spectrum. You could have broadened it.
I'm happy you told me
And
that
second thing,
I have
that
more.
the professionals you are taking, therapists and psychiatrists, special educator and counselors.
Yeah.
Majority of these counselors, special educators and psychiatrists,
Yeah.
they are not trained enough.
Yes, sir.
Psychiatrists, they are only taught the pharmacology.
Yeah.
They don't know about the normal psychological developments and different age group psychological,
Yes, sir.
you know.
Very true. Very true.
Mindness.
Because very true.
And then therapists how many of them were trained therapists or trained counselors?
They were all postgraduates, majority of 60%.
Post-graduation is not training.
But that they were, in terms of how we looked at it, when I gave it to the organization, everybody who has at least completed 1 year was the one who was given out, because they did not give us freshers at all. Because they are new to the organization, they will not allow that, which is something I was sensitive to also. But this is something that the organizational heads would specify, that why is their score higher? Because when I shared it to them, they said, what can we do better? So we did tell that you need to provide further training. So this can lead to organizations thinking what we can do best. It leads to a thought for them, sir. So if I look at it in a way that this is like going and showing the organizations that don't just keep people and make them work. They need training of their own.
That's all right. You could have mentioned that in your, while describing the sample,
Yeah.
that these things were not explored, because if trained therapists are there, the likelihood of vicarious trauma will be less. Untrained people who are entering in therapy, they have more strong and severe vicarious trauma.
Sure, sir. Then that means that when we look at this, probably other factors have also played, like maybe the organization's support to them apart from training, maybe the way they treat in terms of their supervision or how they are talking to their therapist, the non-verbals, all these elements will come in, because this will question the organization to think, if it is a train, because all of them are not freshers, like I said, that was an exclusion criteria, they're not freshers, but what is it that they have to do better? So this will make an impact of a ripple, like I said, it will give them an impact to think how they can help them better. But in order to design a model that worked in itself was starting off by telling them that even if we are trained, sometimes we need help too. That is why that brochure I've made, sir, that sometimes we might also experience it because of continuous exposure sometime in our life. Like if 6 out of 10 people do. Though they were not higher, they were not clinically distressed, but they had moderate scores, which means that they can be handheld before they get into that area, into that level of it. Their participation in itself, I have understood something. The individuals who participated had some idea that they're going to get intervention and help. They were not forced into this, which means they knew that they're coming in to seek help. So this is my personal understanding. That, and I did ask the audience during the time of when we were looking at their belief system, their corporate, they said, we make the worst patients. That's something that one of the psychiatrists said, that I am a trained psychiatrist, but I make the worst patient, Feba. I don't think I care for my triglycerides are very high, my BP is higher. Sometimes I also have that I don't want to go back to work. So it is true that they might be trained, sir, but I've experienced that even individuals who did consent and come, they came with the perspective that something is going to come out of this session. And I hope it did. But at the same time,
psychiatrists are half trained in India. I am working in medical setup.
yes,
And then I have seen the training process in different institutions where they study psychological part of it for sake of study. For example,
yeah,
they don't understand that, and their main focus is, symptomatic treatment.
yeah.
If the
Diagnose
patient is saying he is anxious, one anti-anxiety will be prescribed.
Yeah.
If looking bit depressed, one antidepressant will be prescribed. If talking something nonsense, one antipsychotic will be prescribed.
Sure.
That is where they are trained. main thing is that therapist and counselor, they definitely must have psychological background.
Yes, sir.
So they are well aware of normal psychological development.
Sure.
Stress is integral part of life.
Yes.
Without stress, there is no life.
Yes.
And solving stress is basically process of life.
Correct.
So in that condition, coping strategy is what I was indicating. And secondly, data you have got that good.
Yes, sir.
But while tabulating,
Yes, sir.
in tabulation process, I am just advising the technical part of it.
Right.
While tabulating, you can make out so many inferences in this data. The only thing is that the design of table should be bit different. So that way you can have more information with your hard work
Right.
than what you are showing. And was there any case where addiction history was there? Have you explored that?
So that's why all mental health conditions, like we say in the medical sectors, anything that was to do with addictions, any kind of substance use was ruled out in terms that they was ruled out because that's an excluded criteria. I'm sure they should be honest because doctors have to be honest, I feel.
So what kind of difficulty you faced while collecting data?
Yeah, so it is not an easy task to bring us to the table because I'm honest. Like when I'm doing my attempt to work through, first of all, traveling to India to meet everybody meant I had to make contacts through medical sectors. And I work in a medical sector myself. So humbly, I've been part of a 125-year-old hospital in Bahrain. We speak Hindi because there's 52% of Indians there. But something we face as a mental health department is that I know when it comes to us seeking help, everybody is, they move out, they don't come. So the organizational head said, Feba, do you really think with your whole heart?
There is ego.
Sir?
There is ego.
I don't want to...
Medical professionals consider themselves lot better than a normal person.
Yeah.
So why one should go and ask for any help for a non-medical person?
And imagine what the organization head told me. Was this is another challenge. He would say, do you think people will turn up for your session? I said, let's give it a try. First day, I had only 4 people come in and said that, do you want to do it? I said, let's do it, do the assessment. That's why attempts after attempts was a long process. But that was the journey I learned. I also broke a lot of me in the process, which meant that I also learned that we are not taking care of ourselves, including the psychiatrist whom I work with, right, as a team. If it's live, for sure he will look at it, he'll say, he would have coffee instead of water. So he had to switch that because his levels of cholesterols and BPs started to fluctuate very rapidly. And he would say, we make really poor patients ourselves. But once we get into helping, the environment changed. Today I'm connected to these individuals in different areas. 250 people, it was not bad. It means I made friends. I made people who could come in and say, tough time for me, I had a loss. That's trauma care, which meant it not really limits to this, sir. I feel that there is an impact it can make. I'm a research scholar probably as a student today, but maybe in 5 years down the line, this can become a model of policies, which is something I initiated with the health regulatory there asking, I've done this in India. We have Indians who are working here as expatriates. Can I please put it as a policy? And they agreed. In fact, they came in and saw this as a presentation, which I gave a little snippet of. And they said, how do you want to start it? Then liaising people, the train the trainer program started, sir. You can take a look on it. And 15 people will be there, but they're of different areas. Some will say, oh, I'm doing very well. And I say, let's do a test, because assessment is data, it's numbers. So I say, let's do and see how you're doing. And then to the shock of their lives, even after saying sometimes 2-3 times, they said, why am I not able to, why is it? And then the point is, it is not in mind. Somewhere moderately all are affected, even if we mask to the maximum. Like they don't want to put extremes probably.
So have you planned those sessions in group or individually?
Okay. So the first attempt I did individually, which did not work. Really did not work. So but what happened is out of 10, like I said, 3 people responded it properly. 7 of them I had to push into, go behind. But when I started doing it as an organization, it worked. Like if I talk to the organizational head and say, I need a day when I'm going to talk about vicarious trauma, give out brochures. I will start off this presentation, awareness first. Then I will do the assessment. Let them evaluate, but just give me the scores. So step by step. They said, where are you going to publish it? How is it? I said, nothing. We're just going to do this. You're going to take the scores and I'll come and give you help. After trust building, they did. So if they do it like that, it's done, sir. But if you do it online, Google Forms, the attempts were not good.
So how many sessions you took for intervention?
So this is a 3-day intervention of 25 participants each. So if an organization had only 4 to 5 members, we'll collect in the same place. So I can name 2 because I'm allowed to. But still I feel because we are online. Let us have 2 organizations, they combine their participants. They said, ठीक है, ये दोनों करते हैं साथ में and we will do together. Okay, that's how we did it. And then we had a day, they had snacks because everybody came for the food. Just imagine, I will tell you you asked me my challenges, right? I remember one of the organizations visit, they said, is there food? And we said, there is food because we had snacks post the session. But they came in and they learned and they went. They said, we came in for the snack, but there is something you're talking which makes sense because if you combine the 3, we feel like we should take care of ourselves too. So they went back learning. There are challenges, but sir, I would really like to make this into a project which will...
When that outcomes, 250 cases each, 2 groups. So very, very large sample size for therapeutic intervention, number 1. Number 2, taking professionals. They will not reveal themselves in a group. If you are sitting individual, they may reveal a lot. But while sitting in group, they will hide everything. They will not come out with their real emotion.
Yeah.
So that is a technical part to explore that part.
Can I share something here, sir? I did a certification on trauma-informed care during this process. One thing that I learned is that in trauma-informed care, which is from the US, but it's been applied in countries of Asia, Africa, India, Bangladesh, Pakistan, the entire belt, they're going into trauma areas and doing. They taught me that if you're doing it with, say, Red Cross individuals, or they're doing it with individuals who have a understanding of care, rapport formation should be done in a way that, because rapport formation of the initial bit can really change the way they work. So when I attempted it, because I saw that they are being honest and they saw their colleague is also having the same problem, it works. That's how the other attempt I went forward with. Otherwise, I would have taken an attempt if I see there was feigning of data or if they were not being open. But because this training during that time from the US team of trauma care, which is a very beautiful book that they have written for implementation in collectivistic societies, that taught me some guidelines. Otherwise, it was not possible. Really, I would have gone in and thought that I will do one-to-one, which is something I was in for 250 people, one-to-one. I don't know if I will take 5 years of my learning. My supervisor said, train, then go you train, which is then where we went and searched. Even in the Gulf region, trauma-impacted areas where caregivers are present, they would employ a person who is trained under trauma-informed care to be there and build a rapport. And then individuals started feeling, if you have the same problem, oh, you have it too, oh my goodness, same for me, I don't have a good work-life balance. They started sharing. So this had a good impact, and that's why I continued, sir. If it wasn't there, I would have made an attempt 3. But in attempt 2 with the awareness assessment, awareness, yes, which means sitting down, talking, deliberating, building up that trust with all of them, we could go ahead with attempt 3. Plus, I had to train myself. It was not easy. So I took in the 3 levels of trauma-informed care to also go in step by step and then only provide next. So that's how I got the resources also.
So how many sessions it took for one group?
For one group. Sir, this was a planned model, which means that I told them we will be doing in 3-day process.
Number of sessions.
Sir, this is only a 3-day session, sir. That's it. 3 days.
That you evaluated.
Yeah, because only for collection of data processes. And in 3 days, this is the impact. So which meant, if I make it into a 1-month model, maybe we would have a great training program. Because this was purely for the researchers to finish the data to come into the degree program. Probably that was. But now, maybe Train the Trainer can be a 15-day event. It can be a 1-week event. Because if I show them that 3 days has so much impact, which I did too, like I said, when I met Pooja, that I told her, 3 days, and this is what impact we'll have if we just do a 3-day sit-up with everyone. He said, 3 days getting them to sit. I said, that is something we can plan. So I have understood if we have the right amount of funding, right amount of thought process, right amount of people agreeing, this can be a future model coming out of a patent work, sir. Again, my heart, I don't know, but of course, future holds it, but I'm all convinced on it. I take into consideration the male and female. So those coping strategies, I know that it can have it, but I saw we are failing it even if it is gender disparity. I did read about it. Our self-care is very poor. We do not actually go back home and say, let us do some breathing. We actually go back home and say, let's get to bed. That's what I got an answer from many individuals during my first awareness program. So it's a start of a ripple effect. I hope it reaches somewhere. Yeah.
Anybody else want to ask anything?
I have 3 things which I can find out. First thing is, do you have approval, ethical approval for this work?
Yes.
My certificate is missing here.
I will add it because it took the ethical body some time to give it to me under the health regulatory, but I have it because I'm a representative of a different country.
Well, I'm talking about the Institution of Ethical from them.
Yeah, we have the ethical certificate.
Please show that.
Okay. You mean from the IPR that we took in, no, sir?
We have a separate ethical body, ethical approval body, where you have to present your work and you will get a certification.
Okay, sir, presenting work for the
Because this is a therapeutic work, maybe multiple people affect.
I
had a vice versa effect and.
Okay, so because they are not belonging to LPU, maybe we didn't go up with the supervisor to do it here. But even if I have, sir, I can forward that to you by just checking in because I did it from Bahrain, right? I was a part-time student, so let me just find out. But I have an ethical body certification of me coming to India and doing as participations and so, which is a different letter. But from LPU, I can check in, sir. I can check and send it.
Without ethical clearance, no one can start study. So when you submitted your synopsis,
yeah, it should be there, sir. There'll be a certificate. In my memory, there is a certificate we had done in the start with when I had the previous supervisor. Yeah, then we did it again. Dr. Amin, you were also present in my second DTP, no? Yeah, I think.
There is a proper ethical body here, right?
Which does a certification?
We can say that therapists are there, educators are there. Okay, so we have medical persons are there.
Okay, so give me some time, I'll give you that letter then. I'll add it to that, you mean, no? If it is present.
I think you are talking about the 3-day session or 3 days. So could you please show me every day what you have done, first day, second day, third day?
I have not put it here, but I have a presentation that I did. Do you want to see that one, sir? Like, do you want to see the one that I... this is how I put it through. We started, say, for the day 1.
The thesis that was missing.
Pardon, sir?
That is also not in the thesis.
Okay, we can.
Package what you are giving in the 3 days, that should be clearly.
Okay, day 1, day 2, and day 3 can be added, sir.
Because in my 35 years working in this field, always it took 4 to 5 sessions to break the resistances. When patients start revealing themselves by heart. Before that, in 1, 2, 3 sessions, you will not be able to handle the resistances.
Right. So here we are not moving towards a counseling section, sir. We're only collecting a data, intervening to see.
Intervention session you took, and you are showing the difference, improvement. That is statistical.
Yes, sir.
So then the query will go to technical part of it. Because again, JPMR, a trained person can implement more better than untrained person. The steps are written in the books. Even psychiatrists try that. But they don't get that result what we get when we implement it.
But I've been practicing JPMR since my master's student level. I was trained with...
Under whom supervision?
Pardon?
Who supervised you?
Yeah, so during my master's program, my postgrad, we had the ratio of 4 days of study, 2 days of practice. So I was working with Wim Hans and I was working with AIMS also. During that time, we had a professor.
This goes even everywhere, even in this training program of RCA.
Yeah.
The syllabus is there.
Correct.
But practical training is not given.
Yeah. But sir, I did it continuously for some time. I did it during my postgrad. I practiced it as a clinician even back in my country.
I always demonstrate my students with them, giving myself the training to them.
Right.
First, they have to undergo through their relaxation exercise.
Absolutely.
And after that, what they feel, they develop the confidence to implement it.
Yeah. That's exactly, sir, I believe in too. Like I've taken in all those trainings to even do this. All of it, trauma informed.
Anyway, overall, you did very hard work. It was basically clinical work. So many variables which can affect the outcome that missed, but still, the work is definitely acceptable
Thank you.
and feels good. And then I congratulate you for your doctorate.
Thank you, sir. Thank you.